About an hour and a half ago, I was under a bridge talking with a young lady who just passed her second year of homelessness, unsheltered homelessness. And we were talking about one of the worst things about being homeless for her and for many of the others is not the hunger that they feel or the cold that they feel during the winter, because if they're hungry, we can give them food and their hunger will be satisfied, at least temporarily. We can give them a place to stay and they won't be cold. But it's the intense feeling of hopelessness and helplessness that they feel, and not knowing if they will ever get out of it and if this will ever end. And when I come to these events, I wish I could take them with me and say, do you see these people? They all want this to end for you. And sometimes I think that would mean more to them than almost anything, just knowing that someone knows that they're out there and cares that they're out there. So thanks for hosting this event. So my name is Brett, and I'm the Director of Lehigh Valley Health Network Street Medicine, and the other hat that I wear is the Vice Chair of the International Street Medicine Institute. Street medicine in the Lehigh Valley was founded on two main principles. The first one being that everybody matters, and the second one from a healthcare perspective is that our job is to deliver healthcare, not to decide who is worthy of receiving that care. So with that in mind, we kind of looked at who was not in the waiting room and saw that the homeless were not in the waiting room. And the main reason is because if you know Maslow's hierarchy, the very basement of Maslow is food and shelter. And so that's where we start, because if you don't have food and shelter, you can't begin to move up and care about things like finding a job, about your blood pressure, any other of your healthcare needs, because that's not something that will hurt you now. That's like 20 or 30 years down the road. What I'm worried about now is where I'll sleep tonight, if I'll be safe there, where's my next meal coming from. So that's why I think what you folks all do is so important, is because you are on that very basement of Maslow. And without that, we can't do our job. So that's why I titled the presentation that street medicine is a piece of the housing is healthcare equation. So this camp continues to get reestablished. This was a few years ago, but this is our typical place that we would practice medicine. There were 6 people living in this camp. I tried to get there before it was destroyed, but they lived in this place. They called it the Earthship. And it was made out of soldered together coffee cans with mud placed in between for insulation. And they had a hollowed out air conditioning unit that they used to heat the place for the winter. And one of the things that always inspired me about this was their attention to detail in forming the structure, and the attention that they paid to keeping themselves warm when they didn't have access to food and shelter. So obviously, when the place was destroyed, they weren't able to have the warmth, and we lost them. So then, when they lost their warmth and they lost what little shelter they had, they also lost their health care. We did find them later and were able to reestablish care, but again, it goes back to the importance of the basic food and shelter being taken care of before they can think about their health care. This is a picture of the chimney. You can see it right there. So I wanted to show how inventive they were. And this is what homelessness looks like a lot in the Lehigh Valley. So there aren't people in the Lehigh Valley like there would be in Philadelphia or New York that are sleeping on the streets. And the main reason why is because it's very dangerous. So here, people aren't used to it and they stick out. So they'll get urinated on or beat up, so they retreat into the woods. This camp is an active camp, and it's hard to see it, but in the very back there's a green tent. In that green tent are 2 people. One is a 22-year-old young lady and a 23-year-old young man. They're from the Reading area and were addicted to heroin. They're now 2 months sober from heroin. And the young lady's mother gave her an ultimatum that it was the heroin and the boyfriend or the family. She chose the heroin and the boyfriend. Now the heroin is gone and she's still with the boyfriend. But when she was out there, she let us know that she was pregnant and eventually miscarried. and began bleeding while she was in the woods. So we were there when she placed a phone call, and we were able to get her help. She eventually got what's called a DNC to get everything cleared out, and she's much better. So in a lot of ways, we end up being the most stable thing that they know, and sometimes the only people that they know that are not homeless. So we're there for the tough times and also for the good times. So although the baby did not make it, the kittens did. So these are the little kittens that we're spayed and neutered, and we check on them and make sure that they're healthy. This is just a reminder of Maslow's triangle with the basic physiologic needs that you all address on the bottom. So since we're talking about healthcare and homelessness, because we do healthcare, the homeless are sick. The average life expectancy is 42 to 52 years. The reason for the range is because it depends on what study you look at, but honestly, it doesn't matter. Either way, it's low. There's no other single social determinant of health that I know of that decreases life expectancy by that much. 38% have 2 or more major medical illnesses, 25% with a severe mental illness. Our data is almost 40% with severe mental illness, and 30% with a current drug use disorder. If you look at history of drugs, you're about 90% or more. And they don't use healthcare like the rest of us use healthcare. There's more hospitalization days at greater cost per day. Some of the things that we look at for how we're doing is a length of stay. So the average length of stay in the hospital is about 5 days. Theirs is 4 days longer regardless of diagnosis, just for being homeless. And the 30-day readmission rate is 50% versus about 20% for the housed population. So if you take this all together, you have a population that's very, very sick, uses healthcare in all the wrong ways of no fault of their own, and are not any healthier for it. So this is not good for them, and it's not good for the healthcare system. So this is how we've been addressing the problem. So there's 3 main parts to the program. There's the clinics and the shelters and soup kitchens. Right now we have 7. They're all set up the same way with an on-site pharmacy. We'll draw labs on-site. The whole idea is to deliver as much care on-site as we can, because that's the only way we know for sure that they're getting what they need. Because we believe that everybody matters, not everybody is willing to come into the shelters and soup kitchens. We have the street team, where we'll go out in the woods, under the bridges, wherever they are, and deliver care on-site. I have a backpack with medications, a pharmacy in the back of my truck. We'll draw labs outside. I don't like drawing labs outside because then the day's over. Once you get blood, you have to go. And then the last part is the hospital-based consult service. So if anybody is admitted to the hospital, we'll come see them and help the inpatient team, the hospitalists, understand how their homelessness might be impacting their health care. So is it somebody with a non-healing wound who's sleeping outside next to a stream? That's the same stream that they're bathing in, drinking from, and also urinating and defecating in. So we would know those things and let the inpatient team know how that might be impacting the treatment for their leg. So this is an example of how we might set up one of the clinics. This was the first LVHN street medicine clinic at Safe Harbor. That little girl is my daughter. She was about 2.5 there, and now she's almost 7. But as you can see, it looks like a computer room. Over on that side was a wall that one of the residents built out, and that's where we kept all of our supplies, and when it's clinic time, we brought it all out. So the point is that we take what is already there at the places like New Bethany. We don't come in and take over. So that way, the people and the shelter where we are, the soup kitchen where we are, feel that it's theirs too. It's not just ours. That's my truck and the pharmacy in the back. So part of our role too is to kind of figure out, well, how many people are there, right? We're putting a lot of time and effort into this population, as you are. So if there's like 50 people, 100 people, that matters, right? Because everybody matters, but how much resources do we really put into it? How many homeless are there in the Lehigh Valley? And we didn't really know. So If you don't know a question, you should ask. So we did a study, Screening for Homelessness in the Emergency Department. It was just published this month in Western Journal of Emergency Medicine, in a peer-reviewed journal. If you want to direct your attention to the middle in percent homelessness, so 17th Street is the ER at 17th and Chew in Allentown. CC is Cedar Crest, and MHC is the Muhlenberg ER. 16% that came into 17th Street were homeless. In Cedar Crest, it was 5%. That might not sound like a lot, but there's 25 beds. So at any given, or there's 45 beds. At any given time, there are 2 that are homeless. And I know I'm not getting consulted on them. If you weight these numbers for the size of the ER, because obviously Cedar Crest is larger than 17th Street, you get 7.1% of all patients coming into the Lehigh Valley Hospital qualify as being homeless. That translates to 9,250 patients a year. So you can't say there's that many homeless in the Lehigh Valley, but over the course of the year, that many people experience homelessness that use our ER. And that does not include St. Luke's or Sacred Heart, just Lehigh Valley Hospital. So this is a very significant problem that I don't think we completely understand yet in this area. So part of our responsibility too is to be able to show that what we're doing is working. So we look at all kinds of different metrics because it might sound good, it might be a nice thing to do, but is it working? So one of the things that we mentioned earlier was a readmission rate. So the whole idea of tracking a readmission rate is that if a patient leaves the hospital and they were treated appropriately, they won't come back. So that's the thought. So homeless patients, about 50% readmission rate. And this was ours. So FY 2015, ours was 31%. FY 2016 was down to 12%. So the house population, about 20%. I never thought in a million years we'd get below the house population. But the reason for this is really nothing special. It's just that if you picture how the homeless use healthcare, and that's the only point of entry being through the emergency department. If we got rid of all family doctors, nobody in this room, nobody you knew was allowed to have a family doctor, and your only point of entry was through the ER, you can see how ER visits would skyrocket. That's how they use healthcare. So all we did was provide a different outlet, a primary doctor like we all have, in a location and in a manner that was acceptable to them. That's how we get these numbers. Another thing we focus on is insurance. It's all, the reason why we focus on insurance. Well, for the hospital, they like it because it creates what they call downstream revenue. If a patient comes, then the hospital will get paid for what they do, and it's good that they get paid for what they do. Part of the reason why we care about it is because when they're ready to access healthcare in a traditional setting, they have confidence that they're not a charity case, that they have something to contribute back. So they're more likely to access healthcare in a traditional manner, not necessarily on the street, and do so before they're too sick. So we first were able to track it in February 2015. That's when we got our electronic medical record, and 24% have insurance. On here it talks about fourth quarter of 2015, and now, as we're in 2017, we're consistently in the mid 70% for insurance. So as I think about food insecurity and housing insecurity and kind of where we fit in, I think about this picture. This is a camp in Bethlehem. There was 4 people living in it, and all 4 worked. And none of the employers of the 4 knew that they were homeless. And this was their vanity, that they got ready for work every day. So you can see the broken mirror, the little halved Mountain Dew bottle was their shaving cup. And as you saw in one of the videos, the amount that you have to work at minimum wage to afford a 2-bedroom apartment in Pennsylvania is 89 hours a week. And 44% of the homeless work. It's just not fair to expect people to work 89 hours a week in order to get housing. So that is why I love this picture, because they all worked. Eventually, they were all able to save up enough money and afford an apartment. But the problem with that is that you're relying on 4 full-time salaries for one place. And these are all unstable people. If one of those 4 loses their job, which is likely to happen, they're all back to homelessness. And this was our first street medicine patient. This was a guy, you might be able to tell by looking at him that he had pretty bad lungs. In the year prior to us seeing him, he spent way more time in the hospital than outside of the hospital. He was a Navy veteran. He also had a master's degree from Lehigh and a PhD from Cal. He was a clinical psychologist at the Allentown State Hospital before the state hospital closed. And during that time, he was a functional alcoholic. He would drink during the weekends and sort of sober up enough to work during the week. When the state hospital closed, he became a non-functioning alcoholic. And when we met him, he was staying in the Howard Johnson with one of his old schizophrenic patients. I went to see him in the hospital through the consult service, asked him if I could see him at the Howard Johnson, and he said yes. So he was discharged. I went to see him the next day. He had pneumonia, and he had all these inhalers and steroids and antibiotics, and he didn't have any of his medicine. And I asked him, why you don't have any of your medicine? And he said they wanted $635 for him. Who has that much money to spend a month on medicine? So thankfully, through our program, we're able to get free medicine. So we got him his medicine, but it was too late. The next day, he was readmitted into the hospital. I came to see him in the ER, and I begged them to have physical therapy see him because he walked with a walker. He was in his 70s. Physical therapy saw him, cleared him for discharge home, and he went back to the hotel. I went back 2 days later, knocked on the door, there was no answer. This was at like 10 in the morning. I knocked again, his schizophrenic buddy answered the door, his knee was bleeding, he was drunk. I look through and my patient is lying on the floor with blood coming from his head. The problem was when physical therapy worked with him and went with his walker to make sure he could walk, they didn't do it drunk. So when he was discharged back to the hotel room and was drinking, he fell and hit his head. Thankfully, it was just a scalp laceration that bled a lot, but there was no real damage. And when we went to see him in the hospital, we were able to get him housing through Hope for Veterans, since he was a veteran. In the year after that, he did not have one hospitalization. So it was incredible to see what medications and shelter and sobriety could do for somebody. So when we meet a lot of our patients, this is how they feel. Sorry folks, the future is canceled. Just like the one lady that I talked to before I came here, the feeling that nobody knows that they're out there, that they're nobody to nobody, and nobody cares. But they continue to inspire me with how they deal with the situation, continue to press on. So this is a picture that I took outside of a camp that a guy was living in an overturned dumpster, and this was his front yard. So this liquid yellow-orange thing is his urine. So one of the things you have to pay close attention to is sanitation, because you don't want it, if it's not sanitary, you'll get very sick. So he would urinate in the urinal, and then when it was full, go and dump it outside of the camp. But above that is the book he was reading, Prayer, Faith, and Healing. And I thought it was incredible that here's a guy living in a dumpster with his urine in his front yard, and he's still at hope. So I think more than anything, that's what we try and bring, and I think that's what you all try and bring, is hope that somebody does know that they're out there and cares that they're out there. And even though you see where they're sleeping now and what they have to eat now, that you're not going to forget about them.